say I'm having a lot of trouble kind of getting that quad set. Is there anything else?
Put your hand in there and push it down.
Put a weight down so it helps.
What's that? Okay, so he did do Russian. Okay, Russian I think is a good choice for this person. But if, say your clinic doesn't have Russian, and you're trying to improve, because a lot of times it's almost like, I use the analogy of like a bag of worms. You know, they go to contract and you just don't feel that tight contracting. It's more like, you know, some fluttering, some twitching. Is there anything you can use the patient has to help you? Maybe. Okay, I want you to contract here. Okay, feel this area here. Try to get it to tighten up.
Put the ball under the leg and tell him to push the ball.
Thinking about an associated reaction. Does that help?
Something with the hamstring.
What if you do both your quads together? Okay? So now I'm saying, okay, I see you're having trouble. I want you to try and push your kneecap down into the bed with your good leg at the same time you try to push the other leg. Because remember, you can actually get some overflow into the other muscle. Okay? So tighten, push down, hold. How long are we going to hold a quad set?
3 seconds.
Yes.
At least 5 seconds. Okay? Maybe to start 5 seconds, you know, maybe building up to 10 seconds. Okay? So, and that, again, that's a good exercise. And that might have been good, you did mobilize my patella. Okay, so you moved my patella, but maybe right after, that would have been a good time to start moving my leg. Because again, as the kneecap sticks, it's part of the reason that you don't get good range. Okay, so it's kind of in the way that you sequence things, okay, that helps one thing kind of layer onto the other. Does that make a little bit of sense? Oh, I know. We talked about, again, the importance of getting, what's the importance of getting that knee straight? What's the big deal if I got 10 degree lag? I'm gonna get a contracture, and so my gait will never be right if I have a 10-degree knee flexion contracture, right? Because as I go into heel strike, I wanna be near full extension, and when I'm in stance, I'm almost in full extension. So it will change really my whole kinetic chain, right? And, you know, later on I might have hip pain or back pain because of my gait. So besides this position, kind of waving it, is there another position I can use to help increase or decrease that 10-degree lag? Prone, okay. So prone,
Maybe long low duration.
With a weight on your ankle.
And let it hang.
yeah. So if I go here, right, again, I have gravity helping me, right? Gravity's pushing my leg down. And if I need, I can, you know, take a little weight. I can even take a plastic Publix bag and put something light in it and hang it on the end of my foot. Right? I can do a bag stretch.
Bag drag.
Bag drag. And just stretch it out. Okay? And again, sometimes because gravity helps, it's not as difficult as standing still.
That won't be painful for her.
What's that? Well, it's, you know, total knees are painful. There's not a whole lot of.
But you can't, it's okay to lay it like that.
Yeah, no, I mean, again, you might have to, sometimes people will complain of pressure on the incision, so you might have to like a little bit above the knee, put the towel roll, and then their kneecap doesn't get compressed in. So that might be a little way to remove the pressure coming from there, okay? So that'll be something else they can do at home. What else did Jay not ask about that you might have wanted to know? Okay, pain. You did ask pain at the beginning. He asked me my pain at the beginning.
Weight bearing stuff.
Maybe at the end, he could have asked pain level at the end. What else?
Dizziness throughout the exercise.
Dizziness, okay, we talked a little bit about that. What else was in her eval, or her history?
What about her functional activities? That she does?
Her sitting, okay. Yeah, it was more, right, it was more her knee, a lot of patients will say, I just can't sit still. You know, they're up and walking around, and they really shouldn't be. You know, don't sit for too long. You know, a lot of patients will get at their computer and they forget how long they've been sitting, and again, they got their legs moving out and they get really stiff. I used to tell my patients too, classically when you go see the orthopedic surgeon for your follow-up, you always wind up waiting longer than you think you're gonna wait. So I tell my patients, do not sit still in the waiting room. You can sit for 5 or 10 minutes, and I want you to get up and walk with your walker, and I want you to exercise while you're in the doctor's office, because the doctors are not that nice when they measure range. They just kinda go in there and crank it cold, you know, it's not like when we measure. I said, you'll thank me later, so my patients always come and say, oh, thanks for telling me to, because if I had just been sitting there and the doctor went in and did what he did to my knee, I would've had a heart attack. So again, you always wanna make yourself look good, right, because you want their range to be good when they go in there. So I always tell my patients, you know, you can sit, you can do your toe raises while you're sitting, you can do your sitting heel slides, you can, you know, do some overpressure, all those kind of things that we do in therapy, do while you're waiting for the doctor. Oh, other questions that you might have wanted to know.
Would you ask them how much they can weight bear?
How much they weight bear? What's usual precautions for total knee?
Said partial.
Weight bear is tolerated unless it's cementless, maybe, there might be some weight bearing.
What about the
restrictions.
decreased sensation? The incision?
Okay, so she did have some decreased sensation, so what's significant about that?
You could do desensitization techniques.
So maybe some scar stuff or desensitization. Be careful with modalities. She did have some therapy, right? She had 6 home health PT visits. What she did? What have you done in therapy? Okay, because Jay said,
Oh, that's why you said
ankle
I did
pumps.
that.
I said, oh, I've done these in the hospital. Okay, because obviously they've had therapy in the hospital, right? So what have you done so far? What are you doing at home now? What exercises do you know? Okay, and then it's a good idea to say, okay, show me what you're doing at home. Why do you want them to show you? Because 90% of the time they're doing it wrong. Yeah, so show me what you're doing at home. Okay, well, I do ankle pumps, all day long. When I'm sitting, when I'm watching TV, I do ankle pumps because, I don't wanna get a blood clot, that's what, then, okay, that's good. Then I do, leg raises, straight leg raises. Okay, show me how you do straight leg raises. Okay, so you ask her about her straight leg raise, and she does this. It's not a straight leg. Okay, so remember, she can't quite get her leg straight, but how could we improve it? Come show.
Come hit up.
Come here. So why can't I do a straight leg raise? Go ahead, you can show me, go ahead, show me.
Oh, why can't you do straight? Because you have weak flexion.
Okay, or
Yeah,
what
like a
else?
3 out of
Is it
5
the hip flexion that's
Also,
causing
you can't straighten it out.
so what's causing what we call the lag? What's causing the knee lag?
The hamstring. It's quads.
When I lift my leg, what's causing the quads? My quads. What's the quad's job doing a straight leg raise?
Hold it in extension.
Isometrically contract to keep the knee in full extension. Okay, so it's my quad.
You don't need this.
Okay, so what do I need? What might help to make it better? Certainly you don't wanna hang a weight on me, right, with a quad leg. Okay, so how do I get my quads to engage? What if I quad set first? Okay, so say, okay, I really want you to focus on this muscle, okay, give me maybe some tactile cueing on my BMO, tighten, okay, now lift, hold, and lower, okay? So again, you're just trying to get the quads to engage. The Russian would be a good idea, okay, so maybe you want a Russian stim first, and then work on the straight leg raise, but you certainly wanna educate your patient that if they're doing their straight leg raise like this, they gotta get that knee flat as they can first, okay? And again, you don't really wanna put any weight on there until they're able to do, that they don't have that lag. Okay, you really wanna try to get that extra range, okay? And you tell her at home, hey, before you do your straight leg raises, I want you to sit with that weight on, or I want you to lay prone for 10 or 15 minutes, then do your quad sets, and then do your straight leg raises. Okay, so it's all about kind of the order of the way that you do things. Try to get what you want to get. Does that make sense? Yeah, because you really want to get rid of that lag. You really want to focus on strengthening that BMO. Okay, you could do, you could also work on some short arc quads. Again, focusing on, have them teach them their own tactile cueing. You want to feel that BMO. You want to feel a muscle contracting under that area. And that's that's why the Russian's good, because it helps them to get that connection, okay? Any other questions about straight leg raise?
Well, not about the straight leg raise, but I know he did, 2 types of E-stem. Billing wise, is that allowed to be done?
Probably be okay, yeah, yeah, because one's for strengthening,
Mhm.
one's for pain.
Okay.
He did do a functional activity, sit to stand, which was good. How could it have been better though?
Would you put weight on your foot?
Yeah, make me bend my knee. Every time I sit, every time I went to stand, I stuck my foot out, and every time I sat down, I put my foot out. Okay, so now let's take all that range I just earned in my straight leg raises, okay, active, assistive, and maybe do what Brenna said, come here and do my leaning over onto it, right? So I know Dr. King loves this exercise. Our orthopods in Boston love that exercise too. So we'd always get to the edge of the chair, bend over onto it. Again, you're getting nice overpressure, you have gravity pushing down, you're getting that extra little push that you can't get in a lot of other positions. Rocking chair is good for patients too. If they have a rocking chair at home, they can kind of rock into it, okay? The other thing they can do is use their good leg. You've seen that, right? Where you cross your good leg over and you can pull your other leg back, okay? So again, you're getting a little bit of extra push on the end. The nice thing about that is I don't have to push it, my patient does it, okay? So they're more likely, I think, to go to their end if they're in control of how much that motion is gonna be. So I know I would be. I'd much rather push my own knee. There are gonna be some patients where you're probably gonna have to push it a bit. But again, a lot of patients do better when they're in control of how much they can do. Okay, so, again, just make sure if you're gonna do sit to stand that you're working on now using the range of motion. That's part of it, right? You wanna gain the range of motion so you can use it functionally. And it said she's having trouble transferring on low surfaces, right? So maybe I start a little bit higher, okay, and then as I get better, I can lower the surface, so she's having to go lower through more range of motion. Is there a way I could make that into an outcome measure? Sit to stand. How many times in 30 seconds could I sit to stand? Okay? Or how long did it take me to sit to stand 5 times? How long did it take me to sit to stand 10 times? Okay, so I can make it something measurable that I can measure, okay? And then, maybe then go to my gait, okay? And now let's try to use what range I gained in therapy, in both extension and flexion, as I walk with my walker, or whatever, and use a mirror for cueing, okay, so that you can see what you did. And then maybe after that, what? Okay, so you might maybe wanna, cause you're gonna work on curves, that was one of the things in the plan of care. So maybe you could work on steps. Okay, and how are you gonna finish the treatment? Before you put ice on, what are you gonna do?
Take those measurements.
Take those measurements again, okay? So measure what was flexion, what was extension, maybe ask something about pain at the end of the treatment, what was your pain level, what's your pain level now? So you can kinda have
Would
something.
you do measurements every treatment?
I think you should measure something every treatment. On a knee, I'd measure every treatment.
So when you do RCPM, could you put the towel underneath the Achilles tendon and let the knee
Sag.
Sag.
Mhm.
Would that be a good position to do that?
Yep, be much better than putting a pillow under the knee for the ice. Okay, you really wanna try, and some people don't tolerate it all that well, but, you wanna try to get that knee straight. And you really have to kind of, remind them, because the position of comfort is gonna be a pillow under that knee.
Mm-hmm.
Because they're gonna wanna kind of keep it bent. And again, all of the active motion is gonna help with your swelling too, right? And also trying to get the swelling down will improve your motion. So E-stim is a good thing for that. Even Russian, right, is gonna help, contract those muscles and might help with some of the swelling. Okay, and again, elevation, Jay talked about elevation. Anything else that somebody had written down that they would have done that we didn't talk about?
You said to correct their ways of doing their exercise, home exercise program, right?
Yeah, so if they're doing an exercise that someone, and again, it doesn't mean they were taught that way. It means they're they've been performing it that way. So, you know, don't assume, oh, that therapist, they didn't even know how to teach them how to do a quad set. Because we know what derives from what we teach people becomes this whole different animal. Okay, so, again, one thing Jay did catch, when he told me the heel slide, I actually went into external rotation, and he made me correct it. Okay, so again, always looking at the form, okay? You want the toes to be straight up when you come up to do a heel slide.
Would it be too early to do some gait training on the steps?
No, I think that would be fine. You're probably gonna have to start with a lower step.
Yeah, yeah.
Because of the amount of flexion that she had, but even if you just, you know, work on, again, pretend this is a step, but even if you just work on, you know, getting them to flex their knee on the step. Okay, try to get some of that knee flexion. You know, I think that would be fine to do. Let's see. Anything, anybody else had on their plan?
The only other thing I put on there was, just one leg stance on the knee, on the involved leg. Just so that she's actually wavering on it and balancing on it.
So you're talking about single leg stance on that leg?
With like
You think she's ready for single leg stance
No.
on her upright?
No.
Probably not yet. But some weight shift certainly, okay? And maybe do some weight shifting, or maybe, you know, you could work on, maybe something in the parallel bars where you're having her stand on that leg and bring the other leg through, okay? Yeah, so again, it's just gonna depend on how she tolerates, because remember, she doesn't have that full knee extension. That's the other thing, how about terminal knee extension, standing with the TheraBand? You guys have learned that, right? Tie it around, and maybe that would be a good one for her to work on, trying to get that full extension. Because again, whatever you can do to get those quads to engage, is what you're trying to get. So that might also be a good one.
I myself had on do gait training with Walker, and every 3 or 5 steps, baby duck the uninvolved to get some weight bearing on them.
So you mean this?
Yeah.
Yeah, why don't you just do that? You can do well leg exercises. Yeah, you do both hips. Again, she doesn't have the greatest hip strength, right? At least hip flexion, but 3 plus, over 5. Yeah, so she probably could use some proximal strengthening as well, as she gets to be able to, you know, stand more on her operated foot. What about, probably not yet, but eventually her gait training, you're gonna wanna kind of wean her off the walker, right? You're gonna try to start weaning her off the walker, because again, she walks with her walker all day long at home, maybe not correctly. So we wanna make her gait more normalized, right, with her walker, and then we're gonna start maybe taking the walker away. So, you know, obviously in therapy, we might start walking with her with a cane, or in the parallel bars only using one hand before we've actually turned loose to do that. But you can work on some things so that we can get her off the walker eventually.
If like, strengthening the ankles or hips isn't on the plan of here, can we still add that?
What do your goals say?
Right, they're not on our goals.
Independent with advanced of exercise, increase resting range, normalize gait, up and down 6-inch stairs. So again, in order to normalize gait and be able to go up and down 6-inch stairs, you also need hip strength. Okay, yeah. So you can still work on functional activities and exercise. Okay.
Would,
And it's, I mean, basically your plan of care says Therex. It doesn't say Therex only to the knee, right? And again, you're never gonna treat a knee patient and only treat their knee, right?
So that was the other thing, is hip flexion and, some calf strengthening.
Right, right, so again, yeah, so you might wanna work on some standing toe raises. Yeah. Sitting, obviously sitting she can move now, but yeah, you can do a lot of standing exercises. Always think about at least the joint above and the joint below. And again, we're always kinda thinking about the core, right? Because if somebody's core strength isn't really great, they're not gonna have the proximal stability to move their hips on, right? And if you've been up to see Connie, she works a lot on the hip and the core, you know, proximal stability. So don't forget about that for orthopedic patients too. It's important. And again, a lot of people who've had osteoarthritis for a long time, they've had altered gait for a long time because they've been favoring that leg, you know, while they've been kind of waiting for it to get bad enough that they need surgery. So their hip is probably weak, their ankle's probably weak, their knee, of course, weak if it's their knee. So think about all those things when you're working with them. The other thing to keep in mind is that if your plan of care looks like this, where there's a lot of choices, you don't have to do everything on the plan of care, okay? So if ultrasound's marked, which it isn't on here, but you could possibly do ultrasound. I mean, it would depend on, she's got plastic components, you wanna know that. But just because it's marked on here doesn't mean you have to do it, okay? It kind of gives you liberty to use that modality if you think that modality would be helpful for that patient, okay? In the old days, I mean, therapists back when I first got out of school would get chewed out because they didn't do exactly what was written by the physiatrist up to the dosage of the ultrasound. 1.5 watts per centimeter squared times 10 minutes to write. Really? Most of the time, the funny thing was, usually it wasn't correct. So it got to be a little bit interesting. But those days are gone, thank goodness. So now, you know, we have the, you know, the judgment to be able to use the correct. Now again, if the therapist gives you certain parameters, then you certainly want to use those parameters, unless you discuss that with the therapist. You can kind of change it up. Does that make sense? You don't have to do every single thing that's marked on the plan of care. Anything else anybody had written down?
I had wall slides and mini squats, or would that be too advanced?
It might be a little soon. You might be able to get away with a little bit of mini squats, but remember she's got that 10-degree lag. So you just want to be careful to make sure that she's got enough strength to do it. Certainly that would be in your progression of activities, at least mini squats until you can progress to the wall slides. Which again, this person was pretty active, right? 70, but she was pretty active before. So you're hoping that, you know, you get her back doing those things. Because a lot of our function involves that, right? You don't think about it so much, but, you know, getting dishes down in a cabinet involves having to squat. You know, be able to come back up. You know, if you do any kind of gardening, you gotta be able to squat. You know, grandchildren, you gotta be able to get down, you know, you have to pick up grandchildren. Those kind of things. So it's an important functional activity that you wanna make sure that you work on. Yes.
Since she seems to be reacting poorly to the pain medications, would she be a good candidate? And is there like pain relief iontophoresis? Or is that just with steroids? Swelling?
I would probably not use Ionto with her. Again, the documentation on Ionto is not great, especially with total knee. Now maybe it was kind of tendinopathy, so that perhaps, yeah, but Ionto probably wouldn't be my first. TENS, maybe, what about TENS for pain? Okay, because maybe that would help her, maybe even a home TENS might be beneficial for her, because she could use that, you know, as pain control instead of, you know, because even ibuprofen, after a while, you know, can wreak havoc on your stomach. So maybe TENS might be an option that could be used with this patient, especially for pain control. Or home IFC. Depending on insurance would do. Anything else we'll have written down we can talk about? Oh, we did touch on heat. And why do people say no? Too much swelling. Okay, even though she's, 4 weeks post, but she still had a lot of kind of things that slowed her down. I would say this is probably not classic total knee patient. Most patients don't have so many issues when they're, you know, after post-op kind of complications. So I would say, again, he's probably not ready for some type of exercise, the bike, the rocking on the bike is probably better warm-up for her. Jessica touched a little on the sensation, but she's 4 weeks post, so she probably would be someone that you could actually do some work on her scar. keep it from getting stuck. Okay, at least checking the mobility of the scar, because sometimes it's that is interfering with the range of motion. Okay, so not only the patellar mobility, but also the mobility of the tissue, around the scar, provided that it's, well healed and all that, and again, you just have to assess it and look at it. But, work on the scar, make sure that tissue doesn't get adhesed. Certainly you could do some type of massage, that, works toward, removing any type of swelling or proximal. That would be helpful. Educating the patient on elevating the leg, educating the patient on not sitting too long, getting up and moving around. Doing exercise. How often should they exercise? Every day. So I would even venture to say, more than once a day, especially for trying to get that flexion back. Okay, and anytime, I encourage patients anytime like they're sitting, try and keep their knee bent as far as they can bend it. Okay, don't just stick it out. Okay, just kind of bend it under as far as you can. And then when you think about it, just get a couple of repetitions there besides the time that you do your exercises. Because you kind of have to incorporate it, right? If they're only doing their exercises once or twice a day for that 15 or 20 minutes, and the rest of the day they're keeping the knee stiff somewhere in between flexion and extension, right? They're getting very comfortable in that comfort zone, and they're not moving inside or outside kind of the parameters of it. All right, any other questions on this? So how do you think Jay did? Good. Yeah, so now you can kind of start to kind of put together kind of the whole treatment from the beginning to the end, because some students come back and they're just kind of like, oh, I really didn't even know how the whole thing was supposed to run. And I know some of you have been in clinics before, well, most of you have observed. But you kind of see the flow of how it goes. And sometimes it's hard to, figure out, okay, when you're first treating, it's like, oh God, this poor patient, because I had him down, and then I had him up, and then I put him back down again, and then I was in the chair, and then we walked. So you've got them kind of bouncing all over the place. So, eventually you start to get where, okay, I can group these things together. We can do all these things in this position, we can do all these things prone, we can do all these things in sitting, and then we can do walking, and then we can go back for the modalities at the end. So just trying to, put it together so that you're not having them, prone and supine and sideline and prone, because you don't really have everything organized. And that just takes time, and practice. And again, sometimes it still doesn't work out well because, remember, oh yeah, I'm gonna do this while I have them in that position, and then it's kind of like, oh, I forgot to do it, so you really want to do it, so you go back to that position. So keep that in mind too. All right, how are we doing on time? You want to take a break and we'll do one more case maybe?
Yeah.
All right, so take a break.